to this presentation entitled Integrating Harm Reduction Strategies into Hospital Settings for People Who Use Methamphetamine. This project is being conducted by Dr. Cheryl Forchuk, Dr. Michael Silverman, Dr. Kerry Anderson, and Dr. Abraham Rudnick. My name is John Serrato, and I am the research coordinator for this project. So what is harm reduction? Well, harm reduction is defined as an evidence-based, client-centered approach which focuses on reducing physical and social harms and providing choice, but without the need for abstinence. Methamphetamine use is on the increase in Canada, and a recent study found there's a greater risk of a bloodborne infection as an inpatient in hospital compared to individuals who are outpatients in the community. Of course, this is an area of concern. The objectives of this study are to explore and implement potential harm reduction strategies in the hospital setting. In doing so, we could potentially promote patients' involvement in their care. Many patients who use methamphetamine tend to leave or discharge themselves against medical advice before receiving the care or treatment they need. And that leads on to objective number 3, meeting patients' needs. As well, objective number 4 there is to reduce adverse health outcomes. And lastly, this study will aim to create a method of identification for people who use methamphetamine. This study is a 4-year project. We are currently in year 2, where we are developing the harm reduction strategies to be implemented. In year 1, we obtained recommendations and suggestions from participants with lived experience and healthcare service providers. In years 3 and 4, we shall be evaluating these strategies, again with participants with lived experience and with healthcare service providers who have all been exposed to or have received the interventions. Participants completed an individual interview which contained quantitative and qualitative items. The qualitative items were audio recorded for analysis. Healthcare service providers completed a qualitative interview discussion that is one-to-one or as part of a virtual focus group. The data will be analyzed and evaluated using a standardized framework which includes 4 items. Effectiveness. Does it work and does it produce positive outcomes? Secondly, economic. What are the cost savings? Third, ethical. Does it promote autonomy, beneficence, and privacy for the individual? And lastly, policy. What policies can we inform and how can we support broader implementation of new policies? As you can see from our demographics, the sample was largely male and Caucasian. The mean age was 35.8, and 18 participants identified as members of the LGBTQ2+ community. Here we can see that 70 of the 121 participants had been hospitalized for a psychiatric reason. Of those 70, 31 reported using substances in the hospital. Of that 31, 19 used methamphetamine in the hospital. If you look to the second point, 95 participants reported a physical or medical hospitalization. Of that 95, 38 reported using a substance in the hospital. And of that 38, 16 used methamphetamine. All in all, 94 participants are still currently using methamphetamine, and 56 participants use methamphetamine daily. So from our qualitative findings, a number of harm reduction strategies were recommended. A safe consumption site, and there are 2 types. One is monitored use, where a patient is observed by a healthcare provider, and the other is a safe space, a quiet room for someone to go and use methamphetamine without being disturbed. Other strategies included new needles and syringes, safe substance supply, that is the hospital providing the substance instead of receiving substances from the street, the use of sharp boxes, detox programs, and medication for withdrawal. Issues that did arise, such as stigma, problems with no harm reduction, and barriers and facilitators, were also identified and will be discussed next. Just to go through some of these themes quickly, with stigma, we found those 3 layers of stigma. The perception that addiction or use of methamphetamine is a moral or personal choice. Building from that, there were assumptions around participants' income, their housing, their physical appearance. And this led to social consequences, such as being shunned or feelings of being shunned or ignored. And all of these lead to health consequences, as mentioned earlier, patients leaving, not getting the care or treatment they need. As you can see from this flow chart, on the left side, we can see that patients have three options: to leave or avoid the hospital, to withdraw whilst in the hospital, or to hide their methamphetamine use, all of which lead to negative health outcomes. On the right side, we can see the staff are in a no-win situation. If they accept the zero tolerance absence model that's currently in place, this can perpetuate stigma or lack of knowledge. On the other side, if staff accept harm reduction principles, there is frustration because they cannot implement these. Three types of barriers and facilitators were identified by healthcare and service providers. The first one was attitude and knowledge. Obviously, stigma and lack of acceptance are going to be barriers. However, these can be alleviated through education, greater openness to harm reduction, and community support. Pragmatics, of course, are going to be an issue with resources, cost, space, time, and the availability of methamphetamine on site are going to be problematic. However, through organizational support from leadership, a flexible drop-in program, a specialized team for addictions, and continuity of care after discharge can help facilitate harm reduction. And lastly, the actual safety reduction of harm for staff and for patients were identified. As we have found from our research, methamphetamine use does occur in the hospital. But before we can start implementing harm reduction strategies, we need to start at the core of the issue, which is changing the view on stigma and educating people to understand what harm reduction is and what addiction actually is. In doing so, we can enhance therapeutic relationships, and this may have policy implications. Maybe in the future we can look at safe consumption, or what kind of harm reduction strategies can we implement at this time. In doing so, we can therefore reduce negative health consequences in the future for patients who use methamphetamine. So thank you for watching and listening to this presentation. If you have any questions, please feel free to leave them in the Q&A box. Thanks.